Good morning and welcome to the second episode of our 2023 AARP virtual series on brain health. Today's episode is Doctors and Dementia, Wisdom from Both Sides of the Desk. And I'm so excited about the conversation that we're going to have. I'm Lisa Dedden-Cooper with AARP, and I'm coming to you from our Michigan office. And this, as a reminder, is part of a program that we're hosting every Thursday this month as we dive into what everyone at every age needs to know about brain health and dementia and what we can all do to become more empowered on behalf of ourselves, our friends, our families, and our communities. Issues involving brain health are a priority for AARP because we know they're on the minds and impacting the lives of more and more of our members across the country. For today's episode, we're going to be joined by four really amazing guests. Dr. Jason Karlawish is a physician, author, and the co-director of the Penn Memory Center. And we'll also have three recently retired physicians who are all three now living with dementia themselves. We're going to watch a short video together that those doctors created. And then all of the doctors together will share their perspectives from both sides of the desk, as they say, as both physician and patient. They'll share their insights and tips on how to talk with your doctor about Alzheimer's and other types of dementia, and how to get the type of care and services that you or your loved one needs. And then for the rest of the hour, we want to hear from you, and we'll take your questions live. So if you have questions or comments during today's program, please feel free to type them in the chat box that you see on your screen. It's right underneath the box where our video is playing. So type your questions in the chat box, and we're going to answer as many of your questions as possible. But now, it is my great honor to introduce, just briefly, our guests today. First, I'm very excited for us to be joined by Dr. Jason Karlawish. Dr. Karlawish is a professor of medicine, medical ethics and health policy, and neurology at the University of Pennsylvania, and he's the co-director of the Penn Memory Center. He serves on the governance committee for the Global Council on Brain Health, and he's the author of the fascinating book, The Problem of Alzheimer's: How Science, Culture, and Politics Turned a Rare Disease into a Crisis and What We Can Do About It. Next, we're joined by three physician advocates from the National Council of Dementia Minds. First, Dr. Sarah Langer from Minnesota is a now retired neurologist who had board certifications in neurology as well as electrodiagnostic medicine. Having treated people with Lewy body dementia in her practice, she recognized symptoms of the disease in herself beginning in her early 50s. Next, Dr. Arnold Barish, who's here with us in Michigan, is a retired podiatric surgeon, foot and ankle surgeon. In 2015, at the age of 62, Dr. Barish was diagnosed with MCI and frontotemporal dementia, or FTD. Then in 2022, he was diagnosed with mixed dementia. He's now a well-recognized state and national dementia advocate, and he serves on the National Council of Dementia Minds Board of Directors. And finally, Dr. Gary Schmidt from Wisconsin. He is a retired doctor of family medicine and a former medical director for a nursing home. He was board certified in family practice and also addiction medicine. Dr. Schmidt now has Lewy body dementia. You can read our speakers' full bios, as well as my own, by clicking on the Overview tab on your screen, just below where your video is playing. And in just a moment, we're going to watch a short video together that features Drs. Langer, Barish, and Schmidt, along with several other of their physician colleagues. It's a video created by the National Council of Dementia Minds, which is an organization that they're all part of, that's led by people living with dementia whose mission is to create opportunities for dialogue and education about dementia, or what's sometimes referred to as adult cognitive disorders. Conditions like Alzheimer's and vascular dementia and dementia with Lewy bodies and all the other sorts of dementia that we talked about in episode 1 of this series last week. But first, Dr. Karlawish, can you share a few words with us about what you hope our viewers will take away from today's program?
Absolutely. Well, thank you, Lisa. I'm so thrilled to be part of this. And this is not just professional, this is personal. I could be here one day, and I'm very mindful of that. We're out to meet some very unique and important people. I consider them sort of insider outsiders. They've lived on both sides of the doctor's desk, so to speak. They're smart, they can't be played, dissembled, or otherwise fooled. These are very courageous people. They were participants in the non-system that is dementia diagnosis and care, and now, sadly, they're recipients of the care that that system provides. So listen to them, and they're going to emphasize how the personal experience of these diseases, how personal it is, and it's very important to understand where the person starts out from as an individual in order to figure out what's the cause and how to care for them. Thanks so much.
And I know as well the shortfalls of the current system, and that's what has motivated our guests today, all of our guests, to embark on the mission that they all currently share, to improve the experience that people facing cognitive issues have with their doctors. And that's the mission, the goal that led them to create this short video that we're going to watch next. So let's all watch it together.
I'm Sarah Langer. I am a retired neurologist and was ultimately diagnosed with dementia with Lewy bodies.
My name is Arnie Barish. I'm a former podiatric foot and ankle surgeon. I was diagnosed with mild cognitive impairment with early onset dementia.
I'm Alan Schooley. I'm a pediatrician. I now have Alzheimer's.
I'm Gary Schmidt. I'm a retired family practice physician. And I now have dementia with Lewy bodies.
Tom Mahoney. I'm a primary care internist and also have done a lot of public health work, diagnosed with early stage Alzheimer's.
I'm David Compton, and I'm a retired family physician. I have Alzheimer's disease.
The physicians in this group had as much or more of a problem getting a diagnosis than everybody else. And it's like, holy shit.
Interesting. Everybody has these stories of their early diagnoses being so traumatic. And just confusing. And you're talking about a cognitive disorder, and it's confusing family, confusing for the individual, and unfortunately confusing for the healthcare professionals and industrial medical complex. That's tough.
The response was what I would frequently have told patients. Yeah, something might be going on, but it's not enough for us to catch.
I gave them a list of my symptoms, looking for just confirmation that yes, these symptoms could be from Lewy bodies. And basically what I said was, you don't have Parkinson's, and I'm not sure what to do with all these symptoms.
And it was tough workup. I had all these well-meaning physicians here. You've got attention deficit, take this medicine, or you're depressed, take this medicine. Oh, you need to sleep more, take this. All those medicines make me worse. Everybody's wanting to give it time. It's instead of saying, let's do some more testing. And finally, I got into who I see now.
All too often, doctors will, and this applies to neuropsychologists and all kinds of medical professionals, but they say, well, this person is not 2.5 standard deviations from the mean in their language function. They're not 2.5 standard deviations below the mean in their visual spatial function. They're not 2.5 standard deviations below the mean in terms of their memory function. Therefore, it's no big deal. But the fact is, in reality, real life translates into the summation of these deficits. And their families know that this is a change. But unless you've got somebody strongly advocating for you, you're sunk.
When I was diagnosed, the resource that I was given when I left his office was, I know 2 psychologists on your side of the water that will help you deal with the depression that you're going to have. That was the resource that I was given.
Somebody came in and they talked to me and they said, you should do this and this and this and this, and then you do your what you can, and then just die. And he was like, do you want to die earlier or later? And oh, you shouldn't really do anything that's not, you don't like, and things like so sort of. That's about the best.
Actually, I part of my career, about 20 years, included being a physician on a dementia unit, which is obviously people with very severe, more end-stage disease. But what I never had at the time was a recognition of what can be done in early stage and progression. And I think that healthcare providers, including myself at that time, never had a sense of things that could be done or care that could be given along the journey. The medical mindset is at the end stage without consideration for those of us who still have something to do and to offer.
I have a cognitive loss. I have very early stages of Alzheimer's disease. But if I tell somebody, hi, I have Alzheimer's, they automatically put me in the in their head have put me in the nursing home, staring out the window, or it depends, so I'm going, no, it's not like that.
When books or movies have been done about people with dementia or Alzheimer's, it's almost always looking at the terminal end of it. So that's the outlook that the public has towards it, that this is just a awful terminal disease.
So, it's always there. It's always been there, and always will be. And the question is, how we can change things to make it where people can survive.
People are afraid to diagnose it early. People are afraid to address their symptoms because they're afraid to get that dementia diagnosis. And that's a mistake, because this is a disease that can be modified. And it's like when you think of somebody with diabetes, oh, that's unfortunate. Like, you're using insulin, use pill. That's a disease. You get cancer. Oh, that's really bad. But now in the 50s and 60s, they viewed cancer as that. Just don't look for it. Can't die. You can't do anything about it. Goodbye. Till now, hey, it's treatable. We should take the same approach with these diseases.
If you have a heart attack, they automatically send you to all the right people. And they have you see a dietitian. They start having you do exercise, and they have all these things plotted out. And they give you the medications. If you have a diagnosis of a dementia or a cognitive impairment, I like to use the word cognitive impairment because dementia has this stigma about it. So if you have a cognitive impairment, there really isn't, but there's things that you can do.
So my recommendation is that upon presentation of a patient to clinic with cognitive complaints, a social worker or psychologist, an occupational therapist, a physical therapist, and a speech pathologist all be recruited to assess the patient for cognitive impairment and any other potential psychiatric or physical complaints that might accompany a neurodegenerative disorder. And I think it greatly enhances the diagnosis.
Pay attention to the early symptoms. If somebody comes and say, I'm really struggling with thinking through this, and pay attention to that. Don't just say, oh, it's this, here's a pill. I mean, in medicine, we've gotten to the point of where with plastics, they train, well, here's a disease, here's treatment, then pharmacology. But with changes in the last 3 or 4 decades, it's disease, pills, then treatment. We got it all wrong.
When I was first diagnosed, I looked at organizations that I could turn to, and the most frequent offerings were for the caregivers. The focus was on how do you deal with someone who can't function themselves. And I was really looking for something that told me how to function best by myself.
And that's what I think, what we're trying to do, with this group is figuring out simple things that can help people who have these diseases.
So we set up our support groups, but just people with it, peer driven. No anybody else in the room, just people with it, talk about it. They had a lot to say.
Because they're people that have had life experiences like you have, living the same disease, and you can talk the same language and understand and see how they are functioning well in their environment. What we want to do as a group is somehow reduce the stigma of dementia and educate doctors, nurses, the general population, and what the disease is and how to respond to people when they have the disease, and let them know that we're still people. You don't have to be afraid of us.
What has drawn me to this is to how to live with Alzheimer's, not how to end with Alzheimer's.
Yes.
Wow. As I watched this video, one of the things that strikes me is that if it is that hard for someone in the medical profession to get a diagnosis and the care they need when they are facing possible dementia or adult cognitive decline, how much harder is it for people who aren't doctors themselves?
Exactly.
Dr. Karlowicz, what about you?
Yeah, no, I mean, that's my takeaway, which is you think it's bad out there, it's bad out there. And the fact that people who are insiders had this experience, I think, says everything. Yeah. It's a call to action.
Mm-hmm. In your book, The Problem of Alzheimer's, you describe some of the ways the healthcare field has changed over the years in terms of the options that doctors can offer patients who receive a diagnosis of dementia. So what can patients and their families do to find the right care for them? And how has the landscape changed over the years? How is it changing today?
Yeah. Well, the landscape's gone from really ugly to not so bad, not so ugly, but it needs to get better. And we'll talk about that. Let's start with some of the lessons and takeaways here. We'll start with diagnosis. I think one of the things I take away from my colleagues is the fact that there are symptoms, needs attention, demands attention, certainly not minimization and certainly not dismissal. I think what we want, the core question is, do I have impairments in declines in my cognitive abilities, my cognitive and thinking skills? And if I do, tell me more about what those are. Is it memory, executive function, language, spatial skills? And if I have those problems, one of those at least, what disease or diseases is causing this? That's a very simple set of questions that the physician should answer. And if they can't answer it, I understand. Help me find someone who can answer it. Okay, that's diagnosis. Well, what about treatment? Well, I think the takeaways we have here is ask the question, what do I and the people who care about me need to do to create days that are safe, social, and engaged? And I think the answers, getting answers to these 2-3 very simple questions may require multiple visits to different doctors, one skilled in diagnosis, one skilled in care. It's not always the case that both skills are in the same physician. Accept that, be open to that. You need to demand to know what to expect in the future, not the far distant future of advanced disease, not this end stage thinking, but tomorrow and the tomorrows to come. What should I look out for? What should I plan for? Help me minimize surprises. So there's this idea of moving off of this end stage thinking and none of this nonsense, cruel advice to, quote, check off the bucket list. So I do think that care can be better. And there are 3 recent events that are very encouraging to me. We now are developing and soon to deploy in clinical practice tests that can detect the pathologies that cause some of these diseases, some of the causes of dementia. And these are tests, not simply just imaging tests like MRI scans and PET scans, but blood tests. So we're talking about some relatively easy and affordable tests, but they have to be rationally and thoughtfully prescribed. There are also treatments that can target some of the possible causes of dementia, specifically treatments that target amyloid, which show some promise in slowing down the rate of decline. And finally, and I frankly think most encouraging because it's a systems-wide change that's occurring, Medicare will soon fund demonstration programs across the United States to healthcare systems that apply for this to deliver care coordination, services, and supports for caregivers and patients living with dementia. It's the program that's called Guiding an Improved Dementia Experience Model, or the GUIDE model. Now, healthcare systems have to apply for this and be accepted into it. We're planning to do so, I hope, at Penn. But together, improved diagnostics, therapeutics that are at least targeting one of the possible pathologies, amyloid, and the GUIDE model, they do give me hope that slowly, all at once, I hope, the American healthcare system is finally awakening to dementia. And then America will understand that persons living with dementia, well, they're just that. They're persons, and we should treat them like that.
Yes. And I know our other guests have some suggestions and experiences to share regarding this question. And I'd like to bring them all up on the screen again, too, so we can continue this discussion. And so we can hear from you at home and answer your questions as well. So if you haven't already done so, again, please feel free to type any questions that you have in the chat box that is underneath the video on your screen. And, you know, as we're getting started on this, Doctors Langer and Barish and Schmidt, you can feel free to add any additional thoughts and reactions to what Dr. Karlowicz just said.
It's great to see you guys, by the way.
Thank you.
Greetings again.
And as we're thinking about that, one of the questions I see is come in from Nafisa, who's asking about the 3 of you that just joined us. How long have each of you been diagnosed? I think this is kind of part of us thinking about in helping to educate people about what does a person with dementia look like. I mean, we are here together on this program, and you are people with dementia, and this is what you look like.
I was diagnosed in 2015. So I've been at this for about 8 years now.
And my diagnosis was made probably 4 years ago, but my symptoms began probably 12, 13 years ago and gradually increased as before I got the diagnosis.
Mhm.
And it took a year to get the diagnosis after I first saw the doctor.
Yeah.
I developed symptoms at age 50, actively began seeking diagnosis at age 55, and was not diagnosed until age 60.
And how long
That's
ago
pretty
did you-
typical for what I see.
Yeah.
You know, families, patients have been on about a 1 to 5 year journey of half answers, misanswers, etc.
Yeah. Can you tell us a little bit, Doctors Barish and Schmidt and Langer, about your first symptoms and that you began to experience with your type of dementia?
Well, I had Lewy body dementia. My first symptoms was the disrupted REM sleep, where I hit my wife in the face a couple of times and fell a little bit. Then I had difficulty following conversations. My voice got softer. I lost my sense of smell. But then I started losing memory. I couldn't remember where we went out to eat 2 hours before. I couldn't hang pictures. So those were the initial symptoms before I sought help.
I also have Lewy body dementia, but my very first symptoms were of attention and conversation, concentration. And so, for instance, I'd be listening to a lecture that I was really interested in, and every few sentences, a phrase or a sentence would just drop out, and I'd realize that I'd lost something. And within a year, I noticed that when I was driving and coming up on an anticipated turn, suddenly it would be upon me once again, as if a period of time had just disappeared. And so that was my initial manifestation.
For me, one of my initial things that really affected me was I would go shopping at an area right around the house, but I couldn't find my way home. I started to ignore doing things in my office that I would usually jump on right away. So I started just ignoring things. And as Sarah said, I would go to meetings or lectures, and I found I had to take somebody with me who could help me affirm what I was hearing and listening to.
Mm-hmm. And I see we're getting some really good questions in from our viewers. One of them here from Angela is just like right to the point of what you're all just talking about. So how do you find a doctor to give an accurate diagnosis?
That's probably one of the hardest things. I think all of us, not only in this group, but others, have gone to multiple physicians and frustrated because some of the earlier ones really didn't know what to do for you. And therefore, they either did nothing or tried a medication and said, come back in 6 months, and you realized you weren't really getting care. So you may have to search and move on to something else yourself rather than being referred directly by your doctor.
You know, the advice I give folks, so I work at the Penn Memory Center. It's a clinical center. I think the name suggests what we think we can do. People should be mindful that some places that advertise themselves as memory centers, if you look pretty quickly, you'll see that actually they're more a clinical research center that does trials. There's nothing wrong with that, but their motivation is to bring people in to make diagnoses, to enroll them in research. So they're not really thinking about figuring out the clinical diagnosis and care. Right? My suggestion would be to find someone whose goal is, I'm here to diagnose and treat patients. I think that we should acknowledge that there is no clear pathway to train to become, quote, an Alzheimer's doctor or a dementia doctor. Geriatricians certainly have skills, neurologists do, and some psychiatrists. But even someone who's done those trainings isn't necessarily someone who considers themselves a dementia expert. And if your symptoms are early and mild, I think you need to seek out someone who, frankly, will answer candidly, yeah, I'm comfortable working up early stage disease. If they say, well, actually, no, I'm more whatever, no fair, no foul, no judgment cast, but probably that's not the physician to see. So in summary, just because they're a neurologist doesn't mean they can do it. Just because they're a geriatrician doesn't mean they can do it. Just because you have to ask, and a good clinician will give you a straightforward answer. Their intake desk will.
Yes. And I probably should go quicker with our questions and answers so we can get more of them in there. I do want to reference this particular dementia resource guide. It's an AARP resource that, again, if you look at the tabs underneath the screen, there is a tab that says resources. And there you will find a number of things, but one of them is this guide in English and in Spanish. And one of the things that we have in this guide are some links. And we have a link to the Alzheimer's disease research centers in each state. Not every state, but most states have an Alzheimer's disease research center that's funded by the National Institute of Health, and they specialize, they say Alzheimer's in the name, but they're not just Alzheimer's, it's Alzheimer's and related dementias. I know a lot of folks have had some good experiences with contacting those centers and the doctors in the programs through their Alzheimer's disease research centers in their states. So if you look in the guide, we've got information about how to find that in your state.
Patricia Swarthout asked the name of the program that Medicare will fund. The program is called the Medicare Guide Program. Stands for, I just have to relook at it, Guiding an Improved Dementia Experience, Medicare Guide. It is not a Medicare benefit. It is offered through this, a healthcare system has to apply to become a guide site. So advocate to your healthcare system if you can. Are you guys, gals, going to apply to be a Medicare guide site? And there are two applications. One is to exploratory development, and the other is we're ready to roll it out. So again, it's not a Medicare benefit. It is offered if a healthcare system applies to become a Medicare guide site. And that application process will start sometime before this year ends and be due later next year.
Yes. And I see we have a question from Kayleen about the MOCA test. Often we are, I know AARP and others of us as advocates are out there telling people to talk to your doctor if you think that you may have signs of cognitive decline, and that there is, at least for that initial conversation in the primary care physician's office, a simple test that they can offer to indicate some early signs. So Kayleen is asking about that. Is it that? Is it the MOCA test that's geared to diagnose early symptoms of cognitive decline?
My colleagues may want to weigh in on this.
Yes, it's a fairly helpful screening test that can be applied by any physician. But in my case, I most recently saw a doctor who gave me the MOCA as a screening test. And as someone who does not have memory impairment per se, and who gave this test to my patients daily for years, it was not an appropriate screening test.
Yeah.
So screening tests have a number of advantages, but they are not comprehensive in the way that a more lengthy neuropsychological test can be in pinpointing the cause of the cognitive impairment.
So does
Well
someone in the doctor's office, so say they do get that simple test done in the doctor's office, but they really need this bigger battery of tests. How do they get to that point where they get that other battery of tests? Is it a referral from the primary care physician?
Exactly. A referral to a neuropsychologist. Yeah.
Yes.
And the key thing is to make sure that the referral asks for what the problem is and assistance in working up the specific problem. That helps the neuropsychologist tailor the testing to get answers as opposed to just doing a general battery of tests.
Got it. I see we have a question from Robert. So say we get the diagnosis. How can family members help someone with a new diagnosis to want to find ways to address, to modify, to live with this condition? And he's referring to a family member who is recently diagnosed with early stage Alzheimer's, but they're not inspired, they're not motivated, they're not looking to do any of the things that we talk about that can help, like exercise, for example. How can we inspire people with a new diagnosis to do things that can be helpful?
I think you have to remember that family members are affected by this as much as the patient who has the diagnosis. And there's differences in the different diagnoses between Alzheimer's and Lewy bodies. We all who get the diagnosis are resistant to accepting the fact that we have it. Or we go the opposite end and say, since we're doctors, we see the end disease and there's no hope. You have to be patient. You have to be supportive, have to be understanding. Communication is so difficult between the caregivers and the patient. And we're resistant. I'm resistant, and we mishear what is being said. So don't take offense when they say no. Understand what they're saying.
Yes. Any other thoughts on that? On somebody has gotten a diagnosis, what can they do? What should they do, and what can family members do to help them, with their next steps? I know Brenda actually put a note in the chat about getting involved with peer groups.
So I think a couple thoughts. I think the principle I try to give patients and family members is put together a day that's safe, social, and engaged. Recognize that you can't have all three completely maximized. If it's too safe, it's not terribly social and engaged, etc. That's just sort of a guidance principle. And then I think a couple colleagues here mentioned issues of stigma. And I think self-stigma is a real issue. Namely, the more we talk about this, the more I feel about it, the less I feel capable. And so part of it is the sort of art of, we're going to do certain things, but it's not because of Alzheimer's or Lewy body or FTLD. We're just going to do it, whatever that may be. And to try to walk away from the framing that everything is, because it's about the disease. So, for example, I think that engagement with the arts is a really good way to create meaning and connection between people. And my advice would be go to a museum, for example. But I say, go to a museum because art therapy is really good and it will be very therapeutic for you. It turns the experience of what should be kind of fun into and how many doses a day do we, it medicalizes something that should not be medicalized. And so I think I think it's not to ignore the disease, but it's not to make it the central focus of why we do everything. So it's this interesting balance, I think, between it. Like I prescribed to many of my male patients, the two guys here, I would probably, if they were handy, to do clay classes because men don't think they can do art. Sorry, guys. And yet many of them are very handy, but they gave up their wood shop, whatever it might be. But I've got a couple guys who have thrived in clay classes, and it's not because clay is therapeutic. It's because it will give you something to do that's creative, that's generative, that's fun, and doesn't have all the baggage of, I cut my finger off on the bandsaw or all the other things that can happen. And it gets you out of the house too, which frankly, I think a lot of people struggle to do. So anyway, that's my thoughts.
I feel that the key to living well with cognitive impairment, whether one is affected by the disease or a family member, care partner for someone with cognitive impairment, is the ability to adapt to changing conditions. Yeah. And frankly, that is the key to success throughout one's life. But it means that one can no longer rely on one's own resources. And one has to reach out to others, whether one is affected or a caregiver. You can't do it alone. And so that means involving community in some way, whether it is support groups or other types of social activities, or confiding and getting help from friends in ways that you didn't have to rely on before. It's an acknowledgement that we do have this interdependence. And that's really what makes life rich. So I see this as an opportunity to really engage one another honestly and perhaps enhance our lives and our relationships.
Well said. I mean, I think what you've said is, let me amplify it. Never mind dementia, we all in some way are interdependent in order to thrive with our mind. All that these diseases do is just amplify the importance of that. I think, well said.
I think, excuse me, that like many things, you have to get the family and the person affected to buy in. The fact that they have a problem, the fact that there is something to do, the fact that there is support, as everybody has mentioned, and there is protection when you're in a support group because you realize you're not alone, so that you can ask questions and get answers more directly without fearing that you're going to be judged.
One of the things that we talked about in our first episode and that AARP talks about a lot are the 6 pillars of brain health. These lifestyle choices, behaviors that are important for people, whether you have dementia or not. Staying social, eating healthy, exercising, getting sleep, trying to minimize your stress, and then continuing to learn and use your brain. We talk about these things, I think sometimes in terms of prevention, like I want to do these things so I don't end up with dementia. But we also know that they are good for people whether they have dementia or not. We talked a little about the importance of staying social, staying connected. Like Dr. Karlowicz, you mentioned the clay classes. I know in Michigan, there's out in Grand Rapids, Joyce Bond, who is worked with us, is involved in something called a men's shed. We have memory cafes, opportunities for people to be out being social. But what about some of these others, like the importance of exercise for people living with dementia?
Well, I'd like to hit on that because it was discovered some time ago that exercising skeletal muscle produces a protein called irisin. And irisin was known to help with glucose and lipid control, but more recently, it's been found to be instrumental in maintaining brain function and brain health, both in healthy and in diseased brains. So I think that, again, the point that you're making, Lisa, that these are good principles for living throughout one's life from childhood to old age.
And
I'm seeing in my own practice. I'm sorry, go ahead.
I was going to say a different aspect was the diet that you mentioned. And for me specifically, I started out with the disrupted REM sleep. And living in Wisconsin, I find this difficult to believe. But recently I've read where a Mediterranean diet would affect REM sleep and thus maybe prevent or slow down the progress of dementia. So if 17 years ago, when I first got this diagnosis, if it had been known, which it wasn't at that time, that this type of a diet could have affected it, maybe if I would have changed my diet and had less cheese curds and brats and things like that, I may not be where I am now. So diet and exercise, for sure. And for me, just getting myself motivated to exercise now is so difficult.
Dan Gibbs,
Wisconsin diet.
Dan Gibbs, who's a neurologist.
I'm sorry, Dr.
Dan Gibbs, who's a neurologist who's been diagnosed with Alzheimer's, has written a book about his experience called A Tattoo on My Brain. I highly recommend it. And he speaks about it, his real commitment to exercise and how after he does exercise, he feels sharper and clearer in his thinking. And, frankly, actually, many people will say the same thing regardless of whether or not they have amyloid and tau in their brain, which Dan does. I, right now, as we're in daylight, changes in the sun, amount of sun during the day, every year I predict it, and every year I get the phone calls of changes in cognition and behavior that are occurring in my patients. And my standard prescription is at 4 o'clock, turn the lights on in the house and get out at noon during the day, because we're having these shorter days. And the end of the day where the lights start fading and whatnot becomes a problem. So bring in more light. And the role of a nap during the day as well, a period of time to rest the brain. So I want to emphasize the issues around sleep and the organization of the environment in terms of light, especially as we're going into the sort of winter season where the day is shorter.
Many of the things where Lisa's talking about the pillars can be done, I won't say simply, but by the individual themselves with maybe a partner. The tougher one for me is socialization, because as I was diagnosed, people tend to pull away from me.
Yeah.
We were living in a different state and then moved back to Michigan. And it's difficult at this point, not only with the brain process, but just age and making new connections and meeting new people to stay more social. And the bigger the social environment is, unfortunately, the more I tend to withdraw because of the noise and the crowd that's there.
I have become now, really, I've fallen in love with the concept of memory cafes, which I don't know if that's, again, the right title, but there's this concept AARP and our Lansing, Michigan volunteer team has just set up one called Ethel's Place in Lansing, but it's an idea. Once a month, we have an opportunity for people who are living with dementia and their friends and family to come together and just have social connection, enjoy some music in an inclusive, welcoming setting. And there are about 900 of different sorts of memory cafes around the country. You can look at memorycafedirectory.com and find out if there is one perhaps in your community. They're going to be all different, but it's a place to look for an opportunity for social engagement in a setting where you don't have to feel worried about.
We at the Memory Center, my team led by Felicia Greenfield and Allison Lynn organized memory cafes, and Meg Kalafsky, give them all, acknowledge them all. And one of the key principles of the memory cafes is it's understood that some of the people here may have cognitive impairments, some of the people here may not. The only thing you need to wear is a name tag so that we all know each other's name, but beyond that, that's it. And the programming is designed for everyone to enjoy as they want to participate. So I think they're a model that I think needs to spread throughout the United States. I would also say that adult day activity programs are also a model. Unfortunately, they too are quite variable in the sort of what they do and how they do it, reflecting oftentimes is not just they're underfunded and struggle to make budget, and so they have to make compromises. But we can, as a society, do a better job setting up memory cafes, adult day activity programs. This isn't hard to do. We just have to muster the political will to do it.
Yeah. You know, we have a couple of questions, maybe for Dr. Karlowicz or other doctors about medications. Somebody's asking, is there medication for FTD? Somebody says their doctor has prescribed some medications for them, but no diagnosis, probably Aricept and Namenda. Any thoughts about medications that are out there now? Or
I see the comment there from Gerald Bergler on neurologist prescribes 2 medications but no diagnosis. I don't know the particulars of why or whatnot, but in general, I think a principle when I teach residents and fellows and whatnot is diagnosis, then treatment. And so I kind of would go back to the person that wrote the script and say, what are you treating me for with these medications? Question, and then pause, wait for the answer. In terms of medications, so the advance that has occurred in the last 6-12 months is drugs that target a pathology that is thought to be part of the cascade of events that lead to disabling cognitive impairments have begun to be discovered. In particular, drugs that target beta amyloid, and beta amyloid is one of the pathologies seen in Alzheimer's disease. It's also seen in people who have Lewy body disease, sometimes, not always. And these drugs have been shown to lower beta amyloid. That's fine. So what? But it translates into a slowing of the rate of decline in cognition, measures of function. So what we have are drugs now. There's 2 of them. One's FDA approved. One is up for FDA review very soon. And if the data hold up, likely we'll get FDA approval if everything holds up. That slow the decline. We don't have drugs that target alpha-synuclein, ubiquitin, TDP-43, which are other causes of dementia. There's a tau as well. There are programs underway. I'm part of a group that we're going to meet in about 20 minutes to talk about tau drugs, for example, testing them. So there's a lot of promise there for these other drugs. There are a host of drugs out there, excuse my language, a host of drugs, but there are a variety of drugs out there which, if judiciously prescribed, can help address some of the symptoms, problems with attention, concentration, anxiety, low mood, sleep-wake cycle. I think they need to be tailored to the particulars of the individual, and those are available.
And I know one of the things that we hear in talking about these and some of our other conversations with doctors is you shouldn't be sitting around waiting for a medication. Do these other things. Do the 6 pillars of brain health. Do these other things in the meantime. And I know this is such a great conversation, but I know our going to be coming up against the end of the hour pretty soon. And before we go, I want to ask each of our guests one final question. And I want to remind everybody to tune in for the next 2 episodes in this series. For the month of October, we're here every Thursday at 11 o'clock Eastern Time. And you won't want to miss our next episode. On October 19, I'm going to be joined by 3 guests, and we're going to be talking about Parkinson's disease and other related neurological conditions, including more about Lewy body dementia that we talked about today, and resources for managing and living well with Parkinson's, as well as the other types of dementias that we've been talking about. And I want to remind everybody, especially if we didn't get to your questions either directly or indirectly today, that we do have that resources tab underneath the video screen here, where you can find a lot of the things that we talked about today, including Dr. Karlowish's book, our AARP Dementia Guide. And I want to share that there is another program that Drs. Barish and Schmidt and Langer are all involved in that's going to be coming up. We've got a flyer for that Doctors with Dementia series that's going to be held also on Thursdays, but at 1 o'clock, and those are going to be coming up soon and going through November 16th. That flyer is also on our resources page. But I want to go back to our doctors here with us today, and thank you all for this wonderful discussion and sharing your time and your expertise with us. What is, I'm going to ask each of you, one thing that you will hope that people will take away from today's program? And I'm going to start with Dr. Barish.
Mine's kind of two. Remember that we are all a person and that there is life after diagnosis.
Yes. Dr. Langer, what's the one thing above all that you hope people will take away from today's program?
I think the success in working with one's doctor is to recognize that the doctor takes initially a generalized approach to understanding and diagnosing and treating your condition. But it's important to embrace this idea of adaptation, that you have specific needs and that you will need to respectfully communicate with your doctor what your needs are in a way that you may never have had to advocate for yourself or your loved one before, so that they can understand how this general disease process is affecting you specifically and what help that doctor might be able to give you to meet those challenges.
For you in your specific situation, which might not be the same as somebody else who has dementia. Yes. Dr. Schmidt, what about you? What's that one thing you hope people will take away from today?
There isn't one thing. There's multiple things. I'm sorry. But I think the one thing from my perspective is if you're going into medicine or if you're working with a doctor, things change. There's always change. And what happens today won't be the same tomorrow. And for my disease specifically, today might be a good day, tomorrow might be a bad day, or today is a bad day. Look forward to tomorrow. And as Arnie says, live the days that you have, live the good days that you have. And for your family, take advantage of those good days.
Yes. And finally, Dr. Karlowish.
I'll simply say that, ladies and gentlemen, you had the chance to meet 3 live and in person. and a few others on video, very brave people who had the courage to step forward and say what it is like to be a person living with dementia. And you should recognize that you have just experienced a very privileged moment. Go back and watch this video, watch their other videos. They've got a lot of wisdom. Learn from it.
Thank you.
Thank you. And again, we will have this recorded, and people will be able to access it on that same event page. So you can let your friends and family and others know about it, and they can go in and watch the recorded program. As for me, the one thing that I hope that you will all take away from today is a feeling of empowerment and inspiration to learn more and to live better for yourselves and your families, whether you have dementia or not. So that's all for now. We'll see you again next week. And thank you again for spending this time with us today.
Thank you. Bye, everyone.
Thank you. Bye.
Thank you, everyone.